So I think a little bit different of an afternoon report. It's not a case. It's not a single case. I just wanted to kind of this. I think we're reaching the fag end of residency, and kind of could be my last presentation here at Mornings Invest, and it's been really wonderful working with everyone. So I just wanted to like pass down some interesting cases that I saw and kind of go over some quick learning points. All of these cases were real. I actually experienced them, and I'm going to go over 3 cases to begin with. I'll try and go a little fast so we have time to discuss. If you guys don't mind and you have a chance, if you could screenshot your case, the case presentation, and I'll give you a second at the end of each case, and then you can go out into breakout rooms and discuss what you'd like to do for the patients. You guys can still hear me, is that correct?
We can still hear you.
Perfect, thank you, Sananda. All right, guys. So this is the first case, Ms. Tech. She is in resus room 1. She's 53. She was diagnosed with breast cancer just a month ago. You are the primary team and you're being called to the bedside. She is on a Taxol. She's basically just recently gotten one cycle. She's presenting with worsening shortness of breath for 2 days and is associated with a cough. So on arrival in the ED, she's taken to the resus room because her blood pressure is like a little soft. Her finger sticks 110. She's afebrile. Her blood pressure is 86/56. Her heart rate's 125. She's very tachypnic, so she's on room air. She's just 82%. So EMS puts her on a non-rebreather, and then she's brought to the resus room and then placed on a high flow and a non-rebreather in addition. And then she's stable. She's saturating okay once you do that. So she's got no other past medical history other than this unfortunate metastatic diagnosis last month. She's otherwise healthy 53-year-old, no surgeries, no allergies. She's never a smoker. She lives at home. She's a consultant. And she's very well functional otherwise. And then some background information. She's on basic medications. She got a Taxol, so she's on Zofran. She's taking Tylenol, oxycodone, just as needed, very small doses, hasn't taken anything recently. Only positive review of system is her shortness of breath that's worse than baseline for the last 2 days, and she's got a dry cough. So a little bit more about her. She had an admission 1 month ago when she had actually presented with shortness of breath and basically, unfortunately, found bilateral pleural effusions. The right side was drained. She got a pigtail. It was complicated by an iatrogenic pneumothorax during the drainage, which was treated conservatively with a chest tube, and all of those tubes are out now. She doesn't have any indwelling tubes. The pleural effusion was drained and she was basically sent home for chemotherapy. She only has a PICC line. She doesn't have anything else. And then her liver is kind of replaced with metastatic nodules, which is why she's on therapy. Her exam, she has decreased breath sounds in both her bases, much more distant on the right. She has diffuse crackles bilaterally. She's tachycardic, tachypnic, and has kind of cool peripheries, has some edema, 1+ to trace bilaterally. Her neck veins are distended, but very poorly visualized. She's very tachypnic and kind of tripoding. Her X-ray, we get a portable stat X-ray. It shows obliteration of both costophonic angles, a left greater than right, increased diffuse interstitial markings, and the cardiac silhouette is enlarged. Her EKG shows sinus tach. So that's our first case. If you guys want to go ahead and screenshot this or take a picture of your screen if you're on a laptop, just going to give you a few seconds.
And Avi, if you don't mind explaining just for everyone, is this an afternoon report like others? What are we expected to do afterwards, and what's your plan for us?
Sure. So this is not. I'm not going a traditional afternoon report. I want to discuss a few topics that I thought were important as a third year, as a rising third year, or even a first year, and most often things that patients are called to the bedside for, and we need to act quick. So kind of some pearls. That's the end of the report, but I'm just going to discuss 3 cases. I'm going to give you a brief summary like this. And then we'll go into breakout rooms, and I want you all to think about the possible differentials, what you want to do next for this patient in terms of diagnostics and management, and if you can come up with a one-liner for these patients. I hope that's good enough time for a screenshot. I'm going to go to the next case if that's okay.
Definitely go for it, Navi.
Okay, perfect. So here we go. So next case is Mr. Fall. He is not as complicated. He is in resus room 2. So he's 47. He has no past medical history other than obesity. He's coming to the ED with a syncope.
Recording in progress.
Oops, sorry. It's probably a lot of echo there. All right. So basically, he's coming to the ED with a syncope. He was showering. He just woke up on the floor and helped up by his wife after about 10 minutes. He was just showering. He was doing nothing else. He just passed out. On asking him if he had a similar episode 1 month ago, he says he had a similar episode a month ago. He ignored it. He just thought he was tired. He just passed out. And it was only about 2 minutes. On arrival in the ED, his finger sticks okay. He's also afebrile. His blood pressure is soft, but nothing terrible. He got a little bit of crystallites because the ED was thinking it was a vasovagal syncope. His heart rate's in the 120s on the monitor. It's persisting despite the 2 liters. And he's a little tachypneic, nothing too much. He's belly breathing. He's very obese. He's on 3 liters of nasal cannula since arrival. He's requiring like 2 to 3 liters. He doesn't really need oxygen, but he has severe OSA, OHS. So he's a little hypoxic on and off. He uses a CPAP at home. Otherwise, he has no other medical problems. So he's got no medical history. Just going, if anyone has questions about how he fell down, he just says that he kind of just passed out. He doesn't remember anything. There were no premonitory signs, no chest pain, no shortness of breath, palpitations, no nausea, warmth preceding it, absolutely nothing. He has nothing before it. He just says he passed out, doesn't remember the event. He was probably down for about 10 minutes, felt too weak to get up, and then his wife basically helped him up. So when I was taking his history, he had no medical history. He was on no medications, major medications. Then he tells me that after a lot of probing just before leaving, he tells me he had a weight loss procedure. And I ask him what kind of a procedure. He tells me it was a bariatric surgery for weight loss that he had 2 months ago. No allergies, never smoker, lives at home with his family, has a 10-year-old kid, is very functional otherwise, other than his obesity. It's kind of very odd when I saw him in the ED. He just takes multivitamins after his bariatric procedure. No premonitory cardiac or neuro symptoms. He absolutely cannot remember the event. On exam, he's just morbidly obese. He's a little tachycardic, a little tachypneic. His lungs are super clear. His belly is soft. He has minimal, I made a mistake there. It's not a laparotomy scar. It's a laparoscopic incisions. So like a xiphoid incision and 2 access incisions on the lateral side. He's very warm and well perfused. His neck, he's super obese. I really can't see his neck veins or anything like that. He's warm. And his neuro exam was absolutely unremarkable. No Rombergs, no nystagmus. Pupils were equal, bilaterally reactive, good strength, no dysdiadochokinesis, you name it. Absolutely unremarkable. And then his chest X-ray was read as within normal limits, no airspace opacities, no pneumothorax, angles are preserved, cardiac silhouette enlarged, but unable to interpret given its supportable fill. And then EKG is sinus tachycardia. All right, guys, quick few seconds if you guys want to screenshot this or take a picture of your screens.
Oh, I have a question. Did you
Sure.
mention when was the weight loss procedure?
2 months ago, 2 months before it's in his surgical history. It was 2 months ago. It's like a gastric bypass, a sleeve gastric bypass.
if you have any more questions, they're also welcome, even though it's a different format that
Any more questions are welcome, but I can tell you that for all the cases that I'm discussing, you probably won't need a whole lot of other questions.
And we can also discuss in the breakout rooms if you have any more information that you would like to obtain.
Absolutely. I hope that's enough time to screenshot. I'm gonna go next. Last case, guys. This is Mr. Banker, resus room 3. All right, he's 66. He's got coronary artery disease. He's got a remote PCI, stable HFrEF. He's on baseline medications. His echo was last year. He's coming in with acute onset acute and chronic shortness of breath and cough for 3 days. He is also brought to the resus room, unfortunately. He's occupying the 3rd one. We have 3 in Mount Sinai West. He's febrile, he's tachycardic, he's hypotensive. So kind of everyone's tachycardic, hypotensive, hypoxic, if you get the theme. And he's also tachypneic to like 30. He's pretty hypoxic on room air, also placed in a high flow nasal cannula and a non-rebreather. He's got past medical history, none other than what's already mentioned. No surgical history, no allergies. He is a banker, lives at home, never smoker, no drugs, no alcohol. Very unlike a lot of our population. Meds, losartan 100. He's on metformin. He's taking a Lipitor statin, metoprolol 50 XL, and on an aspirin. He's not on DAPT. It's a remote PCI. He does not have any chest pain. He's mainly having shortness of breath and like a productive cough. I'm sorry, it says dry cough here, but he's also producing some sputum. Exam is significant for diffuse crackles, more on one side. He's tachycardic, tachypneic, not really visualized any neck veins. He's very warm, well perfused. He's febrile. He's got 2+ edema bilaterally, and he's otherwise X-ray, multifocal airspace opacities and interstitial opacities, right greater than left. He's got small bilateral effusion. The silhouette is enlarged. Again, this is a portable film, and it's read as represents as CHF versus pneumonia in the right clinical context. And his EKG just shows sinus tach. All right, guys, few more minutes, a few seconds, and then we can go to breakout rooms, all right? All right, guys, if you've had a good chance to screenshot or take a picture of this, we can, these are her lab. These are the labs. So just for simplicity's sake, obviously all the labs were a little different. Let's for simplicity's sake, presume that these are the labs. It's pretty believable. They're all hypoxic, tachycardic, tachypneic, and a little hypotensive. All of them have a white count with neutrophil predominance. Their hemoglobin platelets are normal. They have a mild AKI. They have a small transaminitis. AST, ALT is mildly elevated. Their bilirubins are normal. Their coags are normal. They all 3 make a small trope, 0.05, have a BNP elevation. And the VBG shows, for simplicity's sake, I'm just going to read it out. They all show a mixed metabolic respiratory acidemia with gap, non-gap, and incomplete respiratory compensation. So it's a metabolic acidemia, gap, non-gap, with lactic acidosis, and the compensatory respiratory mechanism is not fully activated, and their COVID flu is negative. All right, guys, if you want to also take a screenshot, but basically AKI.
Can we go back
sure,
for the case? Just the case, so that I can take it. Can we go back for the case, the 3rd case, so that I can take just a shot? Thank you so much.
Yeah. All right, guys, so things to note: PNP, troponin, small dimer in everyone. The ED has sent this off. ED has sent leukocytosis. one of the patients, the second one is stable because he's been hemodynamically resuscitated and is a floor admission. The other two, you're in a first AC rotation on June 16th and you're being called to the bedside. Think of it as like that. Think of it as that situation, and what do you want to do for this patient? All right, guys, breakout rooms. A few minutes to discuss and one-liner, what your differentials are, how do you want to manage your patient, diagnostic and therapeutic.
Great, we'll see you at 4:30, 4:31. If you have any questions, I'll be rotating in the rooms, right, Abby? I can send you, okay. Now the rooms are open.
Sure, absolutely. You can, yeah.
Everyone is assigned a room. Please join your breakout room. All right. Raul. Frida's in sim lab, so she's not here. Walker and Raul are missing in their breakout rooms. Would you like to join? I'm gonna send you to room 1, just to make sure that people are sort of following. Is that okay?
Yeah.
Okay. No, Raul, just join your room, okay? All right, Abby, I've assigned you to your room.
All right, guys. If one of y'all from team one wants to go down the differentials, if one of y'all want to take the lead from team 1 very quickly, the thought process.
Sophia, Fatma, Yoni, Chris.
Okay, so we mentioned in terms of differentials, so pericardial effusion and tamponade, the accumulation of the pleural effusion. We also mentioned sepsis, given she's probably immunocompromised, lungs being like one of the more suspicious sources. And then I think we also mentioned acute decompensated heart failure and PE. And if I'm forgetting something, then someone else from the group will jump in.
Wonderful, yeah. Wonderful.
They also mentioned lung infiltration or lung metastases as part of the cause for hypoxia.
Yep, filtration. All right. I know Dr. Prigolini wanted to do a much better physical exam with the pulsus paradoxus. It's appropriate, and also Sophia asked for a POCUS. I heard from her, so she wants to POCUS first, and then Fatma said we want to CT pulmonary angiography once we hemodynamically stabilize her. She's a little hypotensive, so kind of rule out PE. Okay, that'll give us all of the information. Team 2.
Rohi, you want to lead your team?
Yeah, sure. So in our group, we summarize this guy as being a middle-aged male with obesity and recent surgery, presenting with syncope, and on arrival found to be tachycardic, hypoxic, and tachypnic. And then our differentials included PE, and then also some like cardiac arrhythmia. We were also thinking if he had some like electrolyte derangements from his weight loss surgery, and then that would lead to either an arrhythmia or some like lack of protein, making him hypercoagulable. But our only thing was he had 2 episodes of syncope, and that kind of went against our PE thought, but still pretty high on the differential. And a little lower on the differential was sepsis. He was tachycardic. hypertensive, but less likely.
What do you want to do first?
We were saying also CTPE. He had an AKI, or like based on the labs, he had an AKI, but still like our suspicion is high enough. It's a life-threatening condition, so still get the CTPE, and then possibly a focus / like echo after all that. If we still think it.
Formal TTE. Okay, wonderful. All right, team 3.
Rohit, want to take a stab at it?
Yep. So we had an elderly gentleman with past medical history of non-ischemic cardiomyopathy with an EF of 35% coming in with, again, shortness of breath and I believe cough. And his labs and vitals suggestive of sepsis picture. He met CIRS criteria. And he had a mixed metabolic and respiratory acidosis with an elevated lactate. So we were considering cardiogenic versus septic shock. But given the elevated D dimer, we cannot rule out a PE. And should I go over the next steps that we were thinking?
Yeah, sure. How do you want to manage him?
Based on like how he looked clinically, we would be cautious with giving him more fluids. Definitely start him on broad spectrum antibiotics. After we've sent like blood cultures and the infectious workup. Yeah, that's pretty much it to initially stabilize him.
So you're going to give him no more fluids?
Depending on how he looks. Yeah, if he was overloaded, we would.
So his neck veins are not visible. His neck's not visible, and his legs are like chronically stasis, little worse than usual. He's 2+, and he's warm, well perfused.
We could do a focus
very warm, and he's febrile.
Okay. We could do a focus at bedside to see the IVC.
Look at his lungs, his IVC.
Yeah.
All right, guys. Thanks for everything. Thanks for sharing your thoughts. I'm going to go ahead and let's see what happened to these patients. All right. So all of these were kind of real patients that I actually saw. I hope you guys can still hear me. So my first patient, so 53-year-old, this was my one-liner, with cool peripheries. She was in shock, and I was not good enough with getting pulsus paradoxus. And I really, to be honest, on all these patients, I saw her, I tried to make it simpler. She did have some distended veins, like I said earlier. And when they're breathing at 35 placed on a BiPAP, it's not that easy to hear heart sounds or lung sounds as well. So I did get help for all of these cases. I got the ER and the critical care team to help with POCUS. And in this case, I got ER and critical care team to help with the POCUS. And these are representational images if someone wants to quickly interpret them from the team. Case 1, guys. Is anyone on?
Adnan, can you give us a hand? Or Sophia, go ahead.
Sorry, no, I didn't hear the question. Can you repeat?
You want to interpret the POCUS for both of these images?
Yeah, sure. I'm on POCUS selective, so if I get it wrong, tell Dr. Rahman. So I mainly see B lines, like it's a B line pattern, and I do see evidence of like pleural, like shimmering of the pleura.
Perfect, wonderful. So you see a seashore sign, you see pleural sliding. Remember, this is someone who had a recent pneumothorax on one side, and now I can't hear breath sounds. So I'm not able to confirm whether there's a pneumo or not, to be honest. And we can get a portable chest X-rays, but with someone so tenuous, small pneumothoraces can tip them over. She has pretty extensive infiltrative disease on her prior CT scan that I reviewed in the interim. The 1 month prior CT scan for staging of her breast cancer actually had severe infiltration. So actually the B lines may or may not be fluid. It can be any alveolar interstitial filling process. It just signifies that there is something. And in her case, it's probably malignancy. And the shimmering of the pleura high up in like the third intercostal space, second intercostal space, you can be pretty sure with the seashore sign that the pleura is moving. All right, and this is what I could see on her lungs. So there's some underlying atelectasis. I'm going to read it out very quickly just for time's sake. And this is her heart. What do we see?
Pericardial effusion.
Yeah, there's a huge effusion with the massive effusion with an RV collapse, RA collapse. In fact, in this case, what happens is basically in a tamponade, your RV, RA pressures are equalized, and also your LV EDP equalizes to the pericardial pressure. So basically had a large pericardial effusion, was eventually taken to the CCU, had a pericardiocentesis, got a drain placed, and shock was managed in the interim with Levofed and covered with antibiotics with broad spectrum. So spot on, everyone. Wonderful. All right, case 2, 47-year-old man. What do you guys want to say about his lung? Anyone from case 2? Anyone from team 2 wants to say what they see?
I mean, unfortunately, I only see Rohi on camera.
Is Matt on? All right, I could read it out. So basically, the right side shows shimmering, the lungs moving. There's a normal A pattern. So I don't know if it's normal or not, but it's not. There's no interstitial or alveolar filling process. That's all we can say. And the pleura is moving, so he's moving. This is both sides, and he's gotten fluids, so he's still hypotensive. He's responded. This is his lung focus, his heart focus. Does anyone want to read this out?
D sign, PE.
Yeah, there's a D sign, which basically means that there's acute RV pressure overload causing the septum to move into the LV during systole. And ideally, it should not be moving into systole because your LV pressure is higher than your RV pressure in systole, which is why it should be like a nice round donut. And this is looking like a D. And then there's also the Connell sign on the right side with the apex moving with the LV because the RV is entirely hypokinetic and it's moving more with the LV. So in this case, actually, he was so not forthcoming with his surgical history. To make it simple, I made him hypoxic, tachycardic, hypotensive. When I saw this guy, he was actually in the ER. Let me tell you what happened. So I saw him as a swing shift attending, not an attending, a swing shift resident in the second year. From 4 to 8, we were slammed with admissions, and as always, we were super busy. And the ER just told me, hey, he had a vasovagal syncope. It was just in passing that he mentioned that, oh, I had a gastric bypass 2 months ago, and he had only syncope. He was not hypoxic. He was only tachycardic. He wasn't hypotensive. So I tweaked it a little bit just to make it easier, and for the case of similarity with other cases. I asked a cardiology fellow to focus him because I felt that he was too young to have any troponin, to have coronary artery disease in the absence of anything. And the very fact that he said, oh, he had surgery 2 months ago as an afterthought. He just mentioned that to me without thinking that this is probably involved in his case or involved in what happened. And so the cardiology fellow called me and said, hey, his RV looks huge. Yeah. Were you saying something, Arohi?
Oh yeah, I was just gonna say. So then, did the ED get like did you get a CTPE, or did they get it because of the dimer? Like, was that dimer real?
No, the dimer was real. The dimer was real. The labs are real. He did have a small dimer, but it was in process forever. The ER hadn't sent it. The dimer came back much later. I spoke to the ER attending saying, hey, I need help with focusing him. He's super obese. I called cardiology because I thought first it's probably CAD. The trope wasn't too high, but he was only 47, no medical history. I had no idea what was going on. And I was going to go home at 8 p.m., giving sign out to the night team. So something that really stuck with me. And the next morning, the pulmonary critical care fellow from Morningside actually sent me a picture of his blood clot that they took out. And this is a real picture. I've saved it because it's so memorable from residency. So this goes into my archives. He had 5 lobes involving everything. And this is a 47-year-old with a 10-year-old kid who had absolutely nothing, no business to have such a huge PE apart from a bariatric procedure recently. And he presented.
Sorry.
And he presented only with a syncope and he was tachycardic. And when we see syncope tachycardia, we by default give fluids, which he got in the ER, and he didn't really respond to it. Any questions?
Yes, I actually had a question. Do you think the previous syncopal episode he had, like, I'm assuming it should be related to that as well?
Highly likely. That's what we were discussing. I mean, he probably had a small PE. He went anticoagulated and the clot expanded.
Because I wonder, like usually when we think about a PE that is so massive, like that is big enough to cause syncope, it should already be quite big, quite large. And it's just interesting to me that he continued just like his usual life without significant symptoms for a month,
right,
after already having such a large PE.
Absolutely.
Like, I don't know, how does that make sense? Like, how did he survive?
Right. I think it's very interesting because young individuals have so much reserve. He powered through. I mean, he wasn't really short of breath. He powered through his tachycardia. He was probably tachycardic, compensating everything, just compensatory. It's not easily explainable, but I think we do see such things in young patients, and this is a real patient, and I remember him very distinctly. So something to keep in mind when someone comes in with syncope and doesn't really give you too much history. Keep PE at the back of your mind, especially this guy who revealed that he had a surgery recently. All right.
It is also likely that being morbidly obese, he must be used to some degree of dyspnea just from the restrictive syndrome.
Absolutely.
So, maybe that, hit really the dyspnea related to the PE.
Right. And also he just had surgery. So he had kind of chalked everything. He was tired. He was a little short of breath. And he said he was chalking everything up to, it was just like, I'm not doing a whole lot now. I'm trying to lose weight and eating better.
Any DVT, Abby?
He did not have it. I believe he went to morning. Unfortunately, he was on like 4 pressors after his CT surgery. And he was in the cardiothoracic ICU. I believe he did not have DVTs, at least proximally that were identified. I don't think they looked at iliac DVTs. He probably had an iliac DVT. All right, just for sake of time, I'm going to power through this. Case 3, very classic. He was in mixed shock. That's his focus. You can see a thicker pleural lining with B lines and a nice consolidation. You can see the liver and the lung above that looks just like the liver. So basically hepatization, red-gray hepatization. And here's his heart. It's barely moving. So very classic biventricular failure. But his IVC was pretty, I'm sorry, I don't think this is moving, but his IVC was collapsed. IVC was very collapsed. So, anyone in sepsis with heart failure, unless they're in flash pulmonary edema, and you're not able to actually oxygenate them well, consider giving some fluids in addition to pressors. So he basically, why is this doing this? Sorry. So he basically had global biventricular dysfunction. So consider giving them fluids. He had a staph pneumonia. He was managed. He was kind of a bread and butter. Septic shock and septic cardiomyopathy, where your heart failure is exacerbated by an infection. He was treated with antibiotics, got intubated, but did well eventually. All right, guys, do we have some time for some discussion on shock, or are we short on time?
I think we still have a few minutes. Just bear in mind,
perfect.
About 6 minutes or so.
All right. Okay. I don't know if we can do this in 6 minutes, guys, but I will try my best. All right, guys. So first of all, what is shock? I want to go over. I'm just going to write stuff out. I hope my handwriting is legible enough. All right. So shock is, what is shock? We just because we see most patients hypertensive and a circulatory deficiency, we kind of chalk it down to hypotension, but shock is basically cellular hypoxia. And three main prongs of that, main reasons. So decreased O2 delivery, decreased O2 ability to utilize oxygen, and what's the third thing? Increased consumption. So shock is basically defined by cellular hypoxia, and the most common cause is decreased O2 delivery due to a decreased cardiac output, and that's why, or decrease in TPR, which is why we kind of chalk shock down to an elevation in lactate and a decrease in blood pressure. But I'm just going to go down some things just so we can see some stuff. So what constitutes oxygen delivery? How do we deliver oxygen? You deliver oxygen with cardiac output, correct? So how do we know what the cardiac output is? Going by the equation, V is IR. You have delta P is cardiac output times total peripheral resistance. Your cardiac output is a measure of heart rate, stroke volume, and a constant, which is contractility times total peripheral resistance. And your P is nothing but mean arterial pressure minus CVP, right? So anything here getting affected is going to decrease your perfusion pressure. This is your perfusion pressure, right? So bear in mind that your venous pressure and your arterial pressures are going to affect how you perfuse an organ. The second thing is, we just talked about, is how are we going to deliver? So oxygen delivery is this, and what you're delivering is cardiac output, but what carries oxygen is your O2 content, right? Now, I don't want you to worry about the equation, but your O2 content is determined by your cardiac output, which we just discussed, times 1.34, which is the amount of oxygen carried by 1 grams per deciliter of hemoglobin, into your hemoglobin percentage into your SpO2, plus 0.0031, which is a constant, times your PaO2, accounting for oxygen that's dissolved in blood. But imagine this fraction is so many decimals, you can actually negate this, which is why it's not super important to know what your PaO2 is. But your SpO2 is what carries oxygen, which is why we focus so much on your SpO2. So anemia, hypoxemia, or mechanisms that mimic hypoxemia, cyanide poisoning, which is not allowing your mitochondria to function, or anything else that's occupying hemoglobin, can mimic shock. All these are shock mimickers, like carbon monoxide poisoning, right? So the third part, delivery, which is 1, 2, oxygen content, and 3, which is consumption. So how is consumption affected? Major factors that affect consumptions are cytokines, which is seen in sepsis, and like I said, cyanide poisoning, and then anything that affect mitochondrial aerobic respiration, all right? So any supply-demand mismatch in any of these factors can mimic shock. So I just wanted to go over this because I think that's super important to kind of understand the mechanism of shock. And your consumption is basically, your consumption is content of arterial minus content of oxygen in venous blood. So to understand this, I don't know if we continue to have time. Just Sananda, let me know when to stop. I will stop. I have a ton to discuss, but I don't think it's the scope of today's stuff. Just want to show you a quick video on Swan-Ganz catheterization so we understand how we're measuring all of this. Let's go to this. All right. I hope this video you can still see. All right. Very quick video. So you can measure all of these variables, and all of these variables actually have a clinical surrogate. Cardiac output with how warm the patient is, right? Oops, I think this is the wrong video playing. Just give me one sec. All right. I think that's a lot. Let me just go over some other stuff here. It's the wrong video that's playing. I apologize. I don't think we have time for all this, but I think I could probably stop here or go ahead and discuss. Sananda, do you think I should discuss mechanisms of shock, or you want me to stop here?
Well, like it kind of depends on your colleagues, but it is 5 p.m. It kind of depends on how long it may take longer than 5 minutes, right, Abby?
Yeah, I mean, probably not. 5 minutes is good enough time.
I think 5 minutes. We can definitely go over 5 minutes.
All right,
we'll start a little late.
All right, perfect. Yeah, so I want to go over a couple of things. Shock hemodynamics. So let's very quickly go over types of shock, and the important things to note is, I'm just going to draw this out real quick. So most common forms of shock. So septic, right? This is how I remember stuff. So shock, S for septic. And clinically, you want to think about IVC, neck veins. What is this a surrogate for? This is a surrogate for your RA pressure and your central venous pressure, right? So either you measure it invasively, or you measure it with ultrasound, or you measure it with clinically in terms of neck veins or IVC. What else are we measuring? That's the preload for your RV. So this is the preload for RV. This is preload LV. Preload for LV is, does the patient have pulmonary edema? And this is pulmonary capillary wedge pressure, or your LV EDP. All right. What is my heart doing? Are you warm or cold? You wet or dry? And how is the tissue consuming oxygen? This is your MvO2, or clinical markers of being warm or cold. And how is your capillary refill? All right, in septic, let's go down really quick. So I want to include this all distributive forms of shock in this. What are other examples? Anaphylactic, adrenal crisis, pancreatitis, vasoplegia, neurogenic shock. Everything is in this. So what happens to the IVC and neck veins? Walk with me. It's decreased. Your veins are empty. There's no pulmonary edema. And this is someone who's responding with tachycardia and increased contractility. There could be a component of septic cardiomyopathy, but someone's with anaphylactic shock or adrenal crisis is at least trying to increase their heart rate, trying to increase what's happening to their cardiac output, right? And one thing that I didn't really include here is the TPR, total peripheral resistance. So in septic shock, your TPR is down, which is your afterload. and myocardial oxygen is increased greater than 65%. And your cap refill is actually mixed. It could be up or down depending on which one is predominated, right? The other forms is SHH is H for hypovolemic hemorrhagic volume loss. So you'll be very dry, a decrease in your preload, very similar to the one above. Very, very decreased preload to your LV. Your heart rate and contractility are trying to go up, right? But what predominates is such low preload that your cardiac output is actually down. So your cardiac output as a whole is down. Your mixed oxygen consumption is decreased because the transit time with mixed oxygen is a surrogate for how long the blood is in circulation and coming back to the right heart. So that's down. And as a response, your afterload goes up, right? You're clamping down, holding down onto all your vessels, trying to perfuse vital organs. Your cap refill is down. So septic shock is about 60%. Hypovolemic is about 15% of patients. The third one is obstructive. What causes obstructive shock? There are two different types in obstructive shock. One is true obstruction with a PE or severe pulmonary hypertension. And the other type is where you have someone auto-peeping, tamponade, auto-peep, constrictive heart failure, constrictive cardiomyopathy, restrictive cardiomyopathy. So what's happening to your preload? Your preload to both RV, to your RV in a PE, your preload is super elevated. The LV is spared. There is very decreased preload to the LV, right? Your cardiac output falls. Your tissue oxygen consumption falls because there's a lot of transit time. Your cap refill is low and your total peripheral resistance is up, clamping down, right? Very similar here, tamponade, your preload to the RV is up. Preload to the LV is also up because this is now not only involving the right side, but also involving the left side of the heart. So left and right both are involved. So your preload to RV and preload to LV both are increased. Your cardiac output's down. This is down. Cap refill is down, and your TPR is up, right? As a response. Last category of shock. So last category of shock is cardiogenic. And then I'm going to let you go. So everything, rate, rhythm, contractility, valvular problems, MIs, vascular problems. So in an RV isolated MI or an RV isolated involvement, your RV preload is up, but your LV is spread. The rest of it just follows the pattern above. And your LV isolated failure or anything else that's involving both the ventricles, your preload's going to go up, preload's going to go up, your cardiac output is down, your mixed oxygen consumption is down, and your total peripheral resistance is up, and your cap refill is low, right? So if you can see, like, tamponade and cardiogenic shock actually mimic each other in terms of which way things move. In an LV failure, it almost looks the same. One way of differentiating it is physical exam, and in addition, the other thing is your PCWP, which is your wedge pressure, is equal to your LV EDP, is equal to your RA pressure, and is equal to your RV pressure. So there's an equalization of pressure in all four ventricles, and that's something that's a hallmark. All right, guys, these are some sources. I'm going to finish up real quick. This is some sources to approach shock. That's from EM Crit, and in fact, it's a really good source that I'd recommend. And if there are any questions, I'll be happy to take them. I've put together the chart from multiple sources, and I'll be happy to make a printed version and share it with whoever's interested.
Thank you so much, Avi. That was an excellent summary of shock. And great presentation. Very, it's a different way to approach afternoon report. We greatly appreciate it. I hope you have a great rest of your afternoon.
Thank you so much, guys.